Welcome to this explainer. Today, we're diving into something truly wild. We are exploring one of the most profoundly paradoxical compounds known to modern neuroscience. Seriously, we're looking at a substance that completely defies simple categorization. It sits right on a razor's edge, somewhere between absolute medical promise and extreme biological peril. It's a massive, complex puzzle, and we're going to break the whole thing down together step by step.
Right off the bat, you have to appreciate this incredible contrast. On one hand, you've got a potential medical miracle. We're talking about a single dose of a root bark alkaloid from the forests of Gabon that reportedly switches off opioid withdrawal and cravings practically overnight, like hitting a hard reset button on addiction. But, and this is a massive but, at the exact same time, this exact same compound can block a critical potassium channel in your body and literally stop your heart. So we're dealing with a substance that forces us to weigh an astonishing potential cure against the lethal biological limit. How do we even get here?
Well, to understand that, let's look at section and accidental discovery, from forest sacrament to Schedule 1.
Ibogaine's history is just fascinating. Its origins actually lie in the West Central African Bwiti religion, where the Tabernanthe iboga root bark is used as a deeply spiritual sacrament. Western science first isolated the compound back in 1901. But here's where it gets bizarre. From the 1930s all the way into the 60s, it was actively sold in France as a stimulant and neuromuscular tonic called Lomboraine. Believe it or not, athletes absolutely loved it. They were basically microdosing a powerful alkaloid before events. Crazy, right? But the real game changer happens in 1962. A 19-year-old heroin user in New York named Howard Lotsof takes Ibogaine, fully expecting your standard recreational psychedelic trip. Instead, when this long, intense, dreamlike state finally fades, he makes a completely accidental discovery. His opioid withdrawal, gone. His cravings, completely vanished. He gives it to his friends, and they report the exact same thing. But, just as Lotsof tries to get the medical community to pay attention, the regulatory hammer comes down. By 1970, the U.S. classifies it as a Schedule I substance, essentially locking away its potential for medical study.
Which brings us to section Rewiring the Brain, the pharmacology of a dirty drug.
So pharmacologists actually call Ibogaine a dirty drug. And no, that doesn't mean it's contaminated. It means it's messy. It doesn't just hit one simple, elegant switch in your brain. Instead, it acts like a single key trying to jam open half a dozen different locks all at once. It binds to multiple neural targets incredibly easily. For instance, it inhibits the NMDA receptor, somewhat like ketamine does. It acts as a modest agonist on your kappa-opioid receptors, which is probably what causes its really intense, often dysphoric, dreamlike effects. And it's also a potent blocker of nicotinic receptors. But here is the absolutely crucial takeaway. Despite the intense visions it causes, it is not a classic psychedelic in the way that LSD or psilocybin are. It is operating on a totally different set of neural circuitry.
Now you might be wondering, how does this one messy drug sustain its anti-addictive effects for so long? Okay, so here's the real kicker. It's all about the split between the parent drug and what it turns into. Ibogaine itself is remarkably short-lived. Depending on your genetics, your body clears it out in just 2 to 8 hours. But the real therapy, that's likely carried by what your liver turns it into. Your body uses an enzyme to convert ibogaine into noribogaine, and noribogaine is the long-lived, active metabolite. It has a half-life of roughly 24 to 49 hours, meaning it dominates your body's exposure for days. This pharmacokinetic split is probably why a single session can suppress that terrible withdrawal cascade over an extended window. It's the noribogaine sticking around and doing the heavy lifting.
Let's actually step through how it induces these structural changes in the brain's reward hub. First, the drug reaches the ventral tegmental area, or the VTA. Once it's there, it triggers an upregulation of a very specific growth factor called GDNF. This biological growth factor basically goes to work structurally rewiring the brain's drug reward circuitry. A landmark study actually proved that if you block the specific GDNF pathway, you block Ibogaine's anti-addictive effects completely. What you should take away from this is that the durable, long-term benefits of Ibogaine seem to come directly from this neuroplasticity. We're talking about actual biological growth, not just a subjective experience of having a trip.
But of course, we can't talk about this incredible rewiring without immediately addressing the dark side. Section, the cardiac limit, the lethal liability of Ibogaine.
The physical danger of this compound is very real, and it is very serious. 19. I want that number to sink in for a second. Between 1990 and 2008, outside of West Central Africa, there were 19 documented fatalities temporarily associated with taking Ibogaine, and a 2012 forensic review found that these deaths didn't show typical central nervous system toxicity. Instead, the evidence pointed directly and fatally to the heart.
To understand why it's so dangerous, we have to talk about the hERG potassium channel. Think of this channel as the reset button for your heart's electrical rhythm. Both Ibogaine and its long-lasting metabolite, noribogaine, block this exact channel at low concentrations. And when you block it, you slow the heart's repolarization. It prolongs what cardiologists call the QT interval, and it can trigger a potentially fatal arrhythmia, which can rapidly degenerate into sudden death. The truly terrifying part here? The doses you need to achieve those therapeutic anti-addiction effects produce plasma concentrations that put you right into this exact danger zone.
So, where do we go from here? Section Engineering the Future. Observational data and state investments.
Because Ibogaine is still a Schedule I substance and unapproved practically everywhere, we see desperate patients traveling abroad to legally gray, totally unregulated clinics. They are taking on immense personal risk. But we are getting strong, undeniable signals pushing the science forward. Take a look at these numbers from a 2024 Stanford study. They followed 30 Special Operations Forces veterans with traumatic brain injuries who traveled to a clinic in Mexico. There, the Ibogaine was co-administered with magnesium to specifically help protect the heart from that exact QT prolongation risk we just talked about. The self-reported outcomes after just 1 month? Absolutely striking. An 88% reduction in PTSD symptoms, 87% in depression, and 81% in anxiety. And importantly, no serious adverse events. Now, we have to throw in a strict scientific caveat right here. This was a small, uncontrolled, open-label observational study on a self-selected group. It doesn't definitively prove clinical efficacy, but man, it is undeniably one of the cleanest, strongest signals we've seen in the literature so far.
All of this creates a ridiculously complex policy landscape. Right now, clinics in places like Mexico and Costa Rica operate largely without binding medical oversight. But to actually mitigate those lethal cardiac risks, safe administration fundamentally requires continuous cardiac monitoring, pretreatment ECGs, and rigorous electrolyte screening. You can't just wing this. Because the observational signals are so strong, policy is actually starting to lap the clinical evidence. Case in point, in June 2025, the state of Texas committed a massive $50 million toward FDA clinical trials for Ibogaine. That is a huge wager that this controversial compound can be made safe enough for standard approval. Simultaneously, researchers aren't just waiting around. They are actively trying to engineer the danger out of it. They're developing safer synthetic analogs like ATMMC that aim to hit the addiction-breaking receptors without ever touching the heart's hERG channel.
Which leaves us with the million-dollar question. Can Ibogaine's benefits be separated from its risks? Can we somehow isolate the medical miracle of addiction interruption and neural rewiring from the sheer biological peril it poses to the human heart? It is truly one of the most high-stakes scientific quests of our entire generation, and the coming years of clinical trials are finally going to give us the answer. Thank you so much for joining me in this explainer. Keep learning, stay curious, and we'll catch you next time.